From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
Welcome to this news roundup. I'm Jennifer Abbasi, Director of JAMA Medical News. Today we're discussing the new CDC recommendations for COVID shots during pregnancy, how mortality from heart disease is changing, and progress towards a vaccine for norovirus. Lead Senior Staff Writer Rita Rubin is here to talk about the new U.S. recommendations for COVID shots in pregnancy. Rita, thanks for joining. Tell us about this update.
Sure, Jen. Even before HHS Secretary Robert F. Kennedy Jr. fired all 17 members of the CDC's Advisory Committee for Immunization Practices, or ACIP for short, he announced two big changes to the CDC's vaccination schedule. He dropped COVID-19 vaccines for healthy children and for pregnant people from the schedule. As FDA Commissioner Marty Makary noted in the video in which Kennedy announced the changes, other countries had already stopped recommending COVID-19 vaccines for healthy children. But no reason was given for dropping pregnant individuals from the COVID-19 vaccination schedule. In fact, when ACIP met for the first time with 7 new members selected by Kennedy, just a few weeks after he dropped the recommendation for pregnancy and childhood vaccines, the committee heard a CDC scientist repeatedly emphasize the importance of COVID-19 vaccination in pregnancy. The reason is that infants younger than 6 months old have never been eligible for COVID-19 shots. They depend on protection from antibodies passed on to them through the placenta from their mothers who've either been vaccinated or recently been infected with SARS-CoV-2, or both. Kennedy's dropping of COVID-19 shots during pregnancy serves as a case study of how he is disrupting the vaccination schedule, which was one of the top concerns by critics of his nomination to serve as HHS Secretary. After all, he was the founder and is a former chair of Children's Health Defense, an anti-vaccine group. Only a small minority of pregnant individuals are up to date with their COVID-19 vaccines, which might help explain why infants younger than 12 months were one of only 2 age groups with hospitalization rates higher for COVID-19 than for influenza during the 10-month period ending in April of this year. Now, not that Secretary Kennedy banned pregnant individuals from getting COVID-19 shots, but he did make it harder. Public and private payers are required to cover only the cost of vaccines on the CDC schedule. Plus, the change has sowed confusion among pharmacists and clinicians. Anecdotally, I heard that pharmacists have been refusing to vaccinate people who are pregnant because the CDC no longer recommends it. The American Academy of Pediatrics, which has been issuing childhood vaccination guidelines since before ACIP was created in 1964, and the American College of Obstetricians and Gynecologists, or ACOG, hope to fill the void. Just today, the day that we're recording this podcast, ACOG announced that it will be developing maternal immunization guidance for respiratory diseases in collaboration with the Vaccine Integrity Project. University of Minnesota epidemiologist Michael Osterholm launched the project in anticipation of efforts by Secretary Kennedy to erode vaccine confidence. One of the issues Osterholm's project will be trying to iron out is insurance coverage of vaccines that are no longer recommended by the CDC.
So, Rita, at its meeting, did the ACIP take any other action related to pregnant women and children?
Good question, Jen. Although the committee members did vote to recommend flu vaccination for everyone 6 months of age or older, they also voted to recommend that pregnant individuals and children and adolescents receive only vaccines free of thimerosal, which is a preservative. Now, thimerosal is rarely used in the U.S. these days, So that recommendation isn't likely to have much of an effect on the types of flu vaccines administered in childhood or during pregnancy. But thimerosal, which has a record of being very safe in medical products, and even the CDC's website still said that the last time I checked, thimerosal has long been used by anti-vaccine activists to link vaccines to autism, which of course has repeatedly been proved to have no scientific basis.
Okay, thank you, Rita. Appreciate the update. Now turning to heart disease, there's new data out on how the types of deaths from this leading driver of mortality in the U.S. have changed over time. And there's a real evolution underway. Joining me now to discuss this is Lauren Schneider, our editorial intern from the NYU Arthur L. Carter Journalism Institute's Science, Health, and Environmental Reporting Program. Lauren, what did you learn about how heart disease deaths are changing?
Thanks, Jen. Heart disease remains the leading cause of death in the U.S., but the nature of these deaths has changed over the past 50 years, according to a new study in the Journal of the American Heart Association. Researchers analyzed the national mortality figures for adults over 25 between 1970 and 2022. They reported that overall, age-adjusted heart disease death rates declined by 2/3. The drop was especially pronounced for ischemic heart disease, including acute myocardial infarction, aka a heart attack. This finding in itself isn't exactly news. Researchers have known since the mid-70s that age-adjusted mortality from ischemic heart disease was declining. But a co-lead author of the new study told me she was surprised by the magnitude. Heart attack death rates decreased by 89%. Within this larger trend of decline, though, the researchers noticed that mortality rates from other forms of cardiovascular disease, like hypertensive heart disease or arrhythmias, rose by over 80%. These conditions were linked to less than a tenth of heart disease deaths in 1970. By 2022, they accounted for almost half of heart disease mortality.
So, Lauren, what accounts for these huge shifts in heart disease deaths?
According to a medical historian I spoke to, researchers have been trying to understand these changes ever since declines in ischemic heart disease deaths were first reported in the 70s. Should advances in heart disease treatment get most of the credit, or does it have more to do with public health initiatives? In the new study, the researchers found multiple inflection points in heart disease death rates over the years, but they stopped short of linking these to medical breakthroughs or policy changes at the time. However, they named several possible influences. Medical factors include improvements in techniques like coronary angiography and angioplasty, better coronary care units in hospitals, and medications like statins, beta blockers, and antiplatelet drugs. They also cited public health initiatives like anti-smoking campaigns and efforts to help people control their cholesterol or blood pressure. I spoke to two specialists in cardiovascular epidemiology, and they interpreted the study results pretty much the same way the authors did. First, they cautioned that an ICD codon doesn't tell the full story on an individual or population level. Aside from changes to the ICD codes themselves across each new version, the criteria for different forms of heart disease have changed over time. The American Heart Association and American College of Cardiologists have lowered the hypertension cutoffs over the years, meaning that more people could be diagnosed with hypertension. That makes it more likely that a patient's eventual death will be attributed to hypertensive heart disease. Doctors have gotten better at identifying these other heart conditions. One epidemiologist mentioned that there was more emphasis on diagnosing atrial fibrillation once researchers determined that treating these patients with anticoagulants could reduce their risk of stroke. With all that in mind, patients who survive an ischemic event are at greater risk for another form of cardiovascular disease in the future. So this new study suggests that patients who previously would have died from a heart attack are now living longer and dying from an arrhythmia or some other condition years later. My sources all agreed that this was good news, but had different perspectives on just how good. After all, if people die from heart conditions caused by prior ischemic events, these events are still causing death in a way.
Okay, Lauren, so what's the takeaway here for clinicians?
To the authors of the new study, these results don't get at more specific demographic trends in heart disease mortality, but they suggest that decades of medical milestones and prevention campaigns have been worth something. Other heart conditions could benefit from this sort of attention. There's a role for research here, but as the medical historian pointed out, we need to make the most of existing knowledge about heart disease prevention. For example, we know that diabetes and hypertension negatively impact heart health, but rates of both are rising. He proposed that policy change could help control these cardiovascular risk factors at a population level.
Thank you, Lauren. Appreciated having you here. All right, next up, norovirus. There's been some important progress in developing a vaccine for this common stomach bug. This could have major benefits to public health, considering how much havoc norovirus causes around the world. Associate Managing Editor Kate Schweitzer is here with an update on the search for a norovirus vaccine.
Thanks, Jen. I'd like to first note that when reporting this story, I learned that norovirus is nicknamed the Ferrari of viruses. It's infamous for how fast it spreads, and if you've ever had it or tried to avoid passing it on, you certainly know all about this. And if not, you've probably heard how this highly contagious stomach bug can race through cruise ships, long-term care facilities, and school cafeterias, and how it leaves sudden vomiting and diarrhea in its wake. Of course, in well-resourced nations, norovirus symptoms commonly pass after a few extremely unpleasant days. But according to those who've spent decades studying this pathogen, it hasn't gotten the attention it deserves. After all, it's the leading cause of acute gastroenteritis. In the U.S., it causes more than half of foodborne illnesses. It accounts for nearly 500,000 emergency department visits each year, mostly for young children, and it's responsible for about 900 deaths annually, predominantly in older adults. In parts of the world with fewer resources, it's a far worse driver of mortality, more like 200,000 deaths, more than a third of whom are children. It contributes to 1 in 5 episodes of diarrheal disease worldwide, and in low-income nations, diarrhea can threaten the health of entire populations, especially those already suffering from malnutrition, chronic starvation, or dehydration. Now, preventative measures like improved water, sanitation, and hygiene have attempted to lessen this burden, which comes with a $60 billion price tag in terms of societal and healthcare costs. But those interventions have all proved ineffective, which is why the World Health Organization prioritized the development of a vaccine back in 2016. But since then, vaccine developers have struggled to create a safe and effective option. Currently, a handful of candidates are in various stages of clinical trials.
Kate, one of your sources remarked how norovirus is, quote, incredibly tricky to manage. So why is this virus so challenging?
You're right. This is where its Ferrari-like powers come in. It's spread not just through contaminated substances like feces or vomit, but it can also spread through the air. You can actually inhale the virus, and just a trace amount of it is enough to cause infection. On top of that, people who've recovered can continue to shed the virus for weeks. It can live on surfaces for even longer. Another source I spoke to calls it the perfect pathogen. She says that what makes it particularly difficult for vaccine developers is its diversity. There are nearly 50 genotypes. Much like the flu, dominant norovirus strains change and evade immune systems. G217 caused most of the cases in the U.S. this past winter, while strain G24, known as Sydney, is the one long associated with the most severe pandemic-level illnesses. Then, of course, there's the issue of immunity. Researchers just don't know how long it lasts after infection. Depending on the study, estimates range from several months to 9 years. So when it comes to vaccine development, scientists have taken several different approaches. One of the most advanced candidates contains virus-like particles, which are essentially empty shells that mimic the size and shape of the pathogen, but lack its genetic material. It's a technology that's been used to protect against human papillomavirus and hepatitis B and E. Although developers have posted positive efficacy data in adults, manufacturer Hillavax announced it failed to similarly protect infants. Moderna has also been sidelined with its development of a single-dose messenger RNA-based candidate. In February, the FDA put a temporary hold on a phase 3 trial after a single reported case of Guillain-Barré syndrome, a neurological disorder. It's not all stalled, however. There's been some notable scientific advancements, like one that has researchers now able to grow the virus in a mini-gut that imitates human intestines. And a biotech company is well underway on trials of an oral tablet.
Kate, the company Vaxart believes a pill form may be the key to preventing norovirus infections at their starting point. So what can you tell us about this oral tablet?
Exactly. This coated tablet is designed to meet the virus where it's at and stimulate the mucosal immunity. In a recent trial, participants were intentionally exposed to norovirus, and 87% of the placebo was infected versus 57% of the vaccinated group. That's a 30% relative reduction. Researchers found that those who received the vaccine shed less virus in their stool and vomit than those who got the placebo, which suggests this pill could slow the spread of the virus. Reduction in the severity of disease symptoms wasn't statistically significant, but that could be due to the fact that participants received higher amounts of the virus than they'd encounter in real-world settings. It's also worth noting that the trial only tested a G1 strain, not the more common G2 strain. But a second-generation version of the vaccine protected against both in a separate phase 1 trial. And following yet another trial, this time focused on breastfeeding mothers, the company announced an increase in norovirus antibodies in breast milk after receiving the pill, which suggests the potential for passive transfer to infants. All this is very promising news, considering that a pill format may be crucial in protecting against a virus with such a devastating grip on resource-limited nations. Think about it. With a pill, you don't need the infrastructure you need with a needle campaign. No trained professionals, you can keep it at room temperature, there's far less medical waste, and it's easier to transport. Bags of pills could be shipped wherever there's a need. It stands to be a real game changer. Of course, it's still hypothetical. Researchers at Vaxart are prepping for phase 2B trials, and experts predict an application to the FDA could still be years away. If and when that time comes, the vaccine will most likely function like flu shots with the need for regular boosters, or it's something that may be administered in anticipation of an outbreak or in advance of travel. And that being said, as one expert clarified, no one is developing a norovirus vaccine just to avoid the occasional cruise ship outbreak, although that's often what garners the most headlines. Like so many crucial vaccinations, it's to protect the world's most vulnerable from potentially devastating and life-threatening illness.
Thank you, Kate. All right, if you'd like to learn more, we'll include links to the stories we discussed in the show description. And you can find all of our stories at jamamedicalnews.com. This month, we also looked into why emergency department stays for older adults are getting longer. We covered the growing importance of including diagnosis codes for heat-related exacerbations of chronic illness. We reported on why meningococcus vaccines appear to protect against gonorrhea, which of course is another pathogen with no vaccine, like norovirus. We published a data brief on the worrisome state of pediatric health and mortality in the U.S. compared with other high-income nations. We highlighted important clinical research from the recent American Diabetes Association conference. And we had an interview with the key scientist behind the field of socially assistive robotics. She chatted with me about how artificial intelligence is helping to advance this technology into clinical trials. You can find that episode in this show's feed, at JAMA Network's YouTube channel, or at jama.com. We'll also drop a link to our video of one of those robots in the show description. Her name is Blossom, and she's super cute. Thanks to Rita Rubin, Lauren Schneider, and Kate Schweitzer for joining me today. I'm Jennifer Abbasi for JAMA Medical News. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.